History of pain, you should ask about location, radiation, character of the pain. How long have you been having this pain? How did it start? Any injury related to this? What's the mechanism of injury? What's the onset? Is it gradual? Is it acute? So all these pain questions should be asked and should be memorized by all students. Continuation of the pain questions, progression. When is this happening? Is it with rest? Is it at night? Constant or only mechanical with walking? Ask about aggravating and relieving factors. Other common complaint is swelling. So the onset of the swelling, duration, whether this is painful or not, whether this is localized or generalized. Also, whether there's fluctuation in the size or this is something constant. How is the progression? Is it fast? Is it slow? And also aggravating and relieving factors are important. Any associated injuries is also very important to ask. Instability is very common in orthopedics, especially in the big joints like the shoulder, the knee. So onset of the stability, how did this start? Any history of trauma? Frequency, how frequent the joint is unstable? What are the triggering factors to this instability? And then usually when we talk about the knee, giving away is a very common complaint. Sometimes patients would complain of locking, or they'll tell you that I cannot trust my leg. So these are the common presentations when you talk about instability. Also, you should ask about the associated symptoms with instability, whether this is causing pain or swelling, but you have to understand what's the main complaint. So mechanical symptoms. What do we mean by mechanical symptoms? It means with the mechanical movement, patient will complain of some symptoms, either pain, instability, locking, clicking. So if you have locking and clicking with motion of the joint, usually there's a loose body or meniscal tear. And there's a difference between locking and pseudo-locking. Locking when there is something blocking the joint from movement, while pseudo-locking when there's just a sense of locking, but there's no real locking. Giving way also can be due to actual instability due to ligamentous injury. And it can be because of an acute pain in the joint that's causing quadriceps inhibition, like cases of patellofemoral pain. It can give the same feeling of instability. Deformity also is very important. So when did you notice this, whether this is progressing or not, associated with pain or stiffness or other symptoms, whether it's affecting function, any past history of trauma or surgery, or any medical illnesses that can affect the musculoskeletal system like polio or neuromuscular disease. Limping also is very common, so you should know whether this is something acute or chronic, any associated trauma, whether the patient is limping because of pain or other causes. Also, progression of the limping is very important, whether the patient is using walking aids and whether this is affecting the function or not. So associated symptoms always should be asked, like swelling, deformity, pain, fever, etc. Loss of function. So this is generalized, but it's usually associated with any musculoskeletal complaint. So you should ask about the activities of daily living, praying, ability to squat or kneel, using the toilet, getting out of a chair or bed, putting on socks, using stairs, how long the patient can walk, getting in and out of the car. Also, how is that affecting the patient's work capacity and also sport activities? So these are very important functional questions to be asked if the patient is complaining of any of the common MSK symptoms. So always keep in mind some important red flags like weight loss, fever, loss of sensation, loss of motor function, sudden difficulties with urination or defecation. That usually indicates something more serious like infection or tumor or coda equina if you're having low back pain with loss of sensation or difficulty in controlling the sphincters. When you assess a patient with any MSK complaint, you should ask about any risk factors that can expose this patient to MSK pathologies. Usually is important: gender, obesity, lack of physical activity, inadequate dietary calcium and vitamin D intake. Smoking also is very important. Type of occupation and sports the patient is doing. Family history, any similar disease. History of infection. And also should ask about all the medications the patient is taking, like steroids can affect the musculoskeletal system. And also alcohol consumption can lead to some other skin manifestations such as avascular necrosis. And also don't forget about asking about important things in the past and surgical history, past medical and surgical history like previous injuries or cancer. When a patient presents with a complaint and you can reach a diagnosis, you should ask the patient, when was he diagnosed with this? Did he get any treatment to improve his complaint or the symptoms? And then it should be detailed in this non-operative treatment. Ask for the type of medications he took, physiotherapy, any orthotics he used, and also ask whether the patient underwent any surgical intervention to manage this problem. And this should be in detail. So special consideration in musculoskeletal system history. So in pediatric, always ask about the pregnancy, whether the patient is full term or not, what type of delivery, any relations between the parents, first degree relatives, for example, can be exposed to inherited diseases. Any ICU admission, any jaundice or blood transfusion after delivery, and also ask about vaccination profile, ask about whether the patient is developing normal milestones, and also when you assess a pediatric patient, you should also ask who noticed these symptoms and when. Spine, very important to ask about radiation of the pain. That indicates nerve compression. Any history of coughing and straining can also cause herniated discs. Sphincter control, as we mentioned, is very important. Can indicate significant cord compression or nerve compression. Shopping trolley, usually patients who's having spinal canal stenosis, they will feel relief when they lean forward on the shopping trolley, so that's very important. Claudication is very important. There is the neuropathic claudication or pain, so that will increase with back extension and walking downhill, and that also will improve with walking uphill or sitting, it means you're flexing the spine forward. If the cause of the claudication is vascular, so if you are walking uphill, that will require more blood flow to the muscles, and then it will give some sort of claudication. And usually when the patient is having vascular claudication, once he stops, standing for a few minutes can be helpful, and that will take the pain away. So it's not related to the position of the spine, rather it's just the time spent to rest. Cervical myopathy also is very important in spine. Should assess the hands, ask if there's any history of coughing or straining. Red flags in spine, very important. Constitutional symptoms like fever, sweating, weight loss, pain at night or rest, and also immunosuppression. Can be also a major risk. Shoulder history, age of the patient is very important. History of instability, acromioclavicular joint injury. Older patients, usually they will have rotator cuff injury more than instability, some degenerative joint disease. Mechanism of injury, usually for dislocation, it's abduction, external rotation, that will dislocate the shoulder anteriorly. The patient is having pain with overhead activities with no clear trauma. This is usually rotator cuff problem. So rotator cuff pain is usually lateral and superior. Patients having bicipital tendonitis, pain can be referred down to the elbow. Also, the patient might have stiffness, instability, clicking, catching, grinding. And that might indicate also some degeneration. The patient is presenting with weakness. Then you should consider a large rotator cuff tear that's called pseudoparalysis. Not necessarily this is because of nerve injury, but sometimes this is caused by large muscle tear, and that will give you pseudoparalysis. Also, you should ask about the functions related to the upper extremity, like dressing, grooming, lifting objects, putting the arm above the shoulder, work and sports. Sometimes you have shoulder pain referred from other organs like mediastinal disorders or cardiac ischemia, so you have to keep this in mind, and the best way to differentiate between both of them is whether the pain is mechanical or not. If you have pain with movement of the shoulder, most likely the shoulder is the source. Knee, it's very common to have ACL injury, so I ask about mechanism of injury, direct or indirect contact, audible pop, did it swell immediately or after a few hours? What was done to manage this initially? Could the patient continue the match or walk on it immediately? These are very important questions for any injuries. Patients who are older and having chronic pain, insidious in onset, usually they're having osteoarthritis, so you should ask about walking distance, walking aids, praying on a chair or in a regular manner, crossing legs or not, ability to do squats, and also the presence of swelling. So as we mentioned, so you have to be, when you assess a patient with an MSK pathology, you have to be relevant. You ask relevant questions to the patient's complaint. Focus on mechanism of injury. Focus on the functional limitation of the patient. And also follow the, standard structure that you used to follow for other specialties. with some modifications to orthopedics. Regarding physical examination in orthopedics is usually straightforward. Start like other examinations, general appearance, take the patient's vital signs. They start examining the patient's gait. I will talk about this in details in the future. There will be clinical sessions in the college. But in general, examination starts with the general appearance, and then look, feel, move. Look, you look for the scars, deformity, swelling, open wounds. Feel, you feel for any bony tenderness. You feel for any difference in temperature compared to the other side or the rest of the body. Move, you start with active range of motion just to see how much the patient can tolerate. And then you can do passive range of motion to see whether there is difference or not. And then you perform special tests for each joint. And that will be discussed in details in the future, inshallah. Any questions?